değerli meslektaşlarım.
Distinguished colleagues, distinguished participants, today we will be listening to Saffet Gönül in this satellite symposium with his presentation on is long-term remission possible in schizophrenia. One of the most important issues during the pandemic is the regular intake of drugs by patients. And psychotic patients, because of the quarantines and lockdowns, were deprived of their medications. It was difficult for them to follow their drugs, to use their drugs regularly. Therefore, long-acting antipsychotics came to the front as an effective alternative. But I believe our main problem in using these drugs, not the main problem, but the main highlight for the use of these drugs is to have better remission, better recovery, or long-term recovery for our patients, and trying to prevent it. And while using it, this issue, he will be talking about all types of long-acting antipsychotics. Let me speak from here. I hope I will not fall down, because I trust in my glial cells in my hippocampus, and we will have an idea about the size of my posterior hippocampus at the end of my presentation. I will be talking about, is long-term remission possible in schizophrenia? If the answer was no, of course I will be making this presentation right now. Many aspects here, but the most important one and the main principle here is the dopamine dysfunction in schizophrenia. And today, this dysfunction is enlightened by some important researchers, Nora Walker, Dean Changpang, and Jane Logan. I had the chance to work with all these people, and I believe I was quite lucky to do so, and I will be able to share some information I learned from them. Of course, when you look at the pathophysiology of schizophrenia, there are many etiological factors, but there are some variants in symptoms, and we need to look at the systems behind these symptoms, and dopamine system dysfunction actually explains 50% of the mechanism behind this disease. And this argument is still valid because we have lots of new drugs nowadays, but at the end of the day, we go back and have to focus the dopamine dysfunction system. So at which level dopamine dysfunction causes schizophrenia? We need to know it well so that we can choose the right drug. And dopamine is produced by tyrosine, and it's released, and some of it is taken back or reuptaken. And during the production of it, or during the release of it, or during its reuptake, there could be some problems, and this may lead to schizophrenia. When we look at the studies conducted, the dopamine turnover is very high in schizophrenic patients, and normal controls, they keep the dopamine within the cell, but schizophrenic patients, when releasing it slowly, we see that there is a continuous release of it in schizophrenia patients, so there is a high level of turnover. And when we look at the patients, especially during the acute period, the release of dopamine is much higher when compared to healthy controls, and we know that there is some increase even in stable patients. And when we have the bursting activities, we see that they are more frequent in acute period, acute episodes, and in stable patients, we see that there is a continuous release of dopamine that is more frequent. And when we look at it from a drug perspective, so we are not changing this process with the drug. It's not drug dependent, the release style. And when we look at the children or their siblings, the people who have these schizophrenic markers, we see that they have a higher level of dopamine release. Therefore, even before the disease onset, this is also shown by some studies, the dopamine release is much higher before the disease onset, and in time it goes up, and after a while it starts to show the symptoms of the disease. Now, dopamine receptors, how did I change based on this activity? Because this changes the postsynaptic system as well, and we can only reduce the dopamine to understand this, because there is always dopamine. It's like a pool. Presynaptic and postsynaptic neurons are there, and inside that pool there should be some amount of dopamine. This is the level of dopamine there should be. But in schizophrenia there is much more than of it. Therefore, we need to reduce the water level of this pool, and we use alpha MPT, and then we reduce the water in the pool, we reduce the dopamine level, and then we can look at the receptors. First of all, there is an increase in dopamine receptor numbers. This is logical, because if you have lots of something in an environment, then you will have some free area, and there will be more neurons. Therefore, in schizophrenic patients, postsynaptic receptor number is higher, and a significant amount of them are connected with the dopamine. They are occupied with dopamine. Therefore, there is continuous stimulation. When we say continuous, of course, the dopamine does not go and bind to the receptor and stay there for 24 hours. This is not the case. It binds and stays there for a while, and then it goes away. So, if we do not have a dopamine system, we cannot have prediction errors, and we cannot think anything about the future. So, the postsynaptic neurons produce more receptors. Of course, this is not the only change. The dopamine receptors are in the dimer structure. So what does it mean? There are two receptors, and there are actually four. There are some in the inside. The screen is too bright. Sorry, I cannot see it clearly. And if one of these receptors is bound by affiliates with the dopamine, then the next one has less binding. And in schizophrenia, you have a high level of dopaminergic stimulation. Therefore, this stimulation, with the new stimulation coming in, the postsynaptic receptor actually changes the dimer structure, and it turns into monomer structures. This is why we have a high sensitive level of dopaminergic production. When there is an increase in dopaminergic release, after a while, I mean, it starts in childhood and sometimes adolescent period, and the postsynaptic receptors become more and more sensitive. In twins as well, who do not have the disease, we can see the same monomer structure. So what do we have for this? according to the information we have, yes, there is dopaminergic pathophysiology, and this explains the schizophrenic symptoms. And there is a high level of turnover, therefore we have a problem with regards to the turnover. And finally, the postsynaptic receptors change in terms of structure and sensitivity, and during the disease they continue to change, and there is the super sensitivity coming in, and while trying to reduce the dose there comes the super sensitivity psychosis. Therefore pre and post synaptic structures are affected. But there's something else. When you look at the studies conducted, there was a very famous study, and it was about quetiapine and clozapine. And could we intermittently block the dopamine receptors rather than doing it continuously, so that we can prevent the supersensitivity, the structure change? But the studies showed us that in the treatment of schizophrenia, 80% of the patients need continuous dopamine blockage. Why do they need it continuously? Because 60% of the postsynaptic receptors should be blocked continuously at around 60%, and unfortunately intermittent blockage can be useful too. Therefore, if we give an antipsychotic drug or antidopaminergic drug, our purpose is to keep the receptors, 60 or 70% of the receptors, to have a blockage for around 24 hours. So, in schizophrenia, we know that there is an increase in dopamine production and release, and we know that the dopamine level in synaptic range is high, and it increases during the exacerbation, and in chronic phase it goes back to normal. So, we may need to give more drugs in the acute period, in the exacerbated period, because for the antipsychotic drug to be binded, it needs to compete with more dopamine. Therefore, when it goes back to the stable level, we can reduce the drug dose a little bit. But this reduction is around 10% every 2-3 months. If you reduce it further, then sensitive dopaminergic receptors may relapse.
Peki, daha iyi bir şey var galiba. Şimdi tabii şöyle bir şey var. Konuşma
Here,
sırasında
during the speech, motor cortex
visual sistem
and the visual system
koordine olduğu vakit
coordinate, and then I can share more information if I have a laser pointer in my hand. Anyway, let's focus on the premotor cortex.
Peki. Her neyse. Şimdi şizofreni ve antipsikotiklerin tedavi seçenekleri.
Schizophrenia, antipsychotics. We know that there are treatment options, and these options are compared since 1950s, and it could be medical therapy or cognitive therapy or antipsychotics. The best results are provided by medications, and with medications, every therapy that is given, every treatment that is given
Çıktığı gibi diğer tedavilerinde çok daha üstünde oluyor. Dolayısıyla
can be much better. Yes, we have the drugs. They are actually the main option for treatment, but we do not give up the other treatment options. We do not just say that, okay, we give the drug and everything is fine. This is not the case.
hasta stabilize
in the long term, if our patient is stable, what can we do? If the patient is stable and using his drug regularly, after 6 months, we only see relapse in 20% of them. However, if they do not use his drug regularly, we see a relapse in 50% of them. And in the first year, we see that there is a relapse rate of 30% in patients who use their drugs regularly for 1 year. If they do not use their drugs regularly, then they have relapses. Almost 80% of them have relapses. And they come to me and say that we have a colleague or a friend, he's not using this drug for 1 year. It's okay, maybe he's stable and this is why he doesn't use the drug. And the other thing is, sometimes you stop using the drug for just 1 day or 2 days, the relapse risk increases by 5%. But if the patient stops using the drugs for a couple of days every month, let's say more than 10 days or 15 days, then the risk of relapse reaches up to 20% and more. Therefore, of course, these are not new data. We have known them for a while. So, long-acting antipsychotics, when they are used, especially between the first 6 months and 1 year, there is no change between the controlled trials. The relapse rates in both groups are similar. However, for patients who continue long-acting antipsychotics, the relapse rate does not increase, but after 1 year, in patients who receive oral antipsychotics, the relapse rate increases because they have some problems with their drugs. When we look at the treatment compliance, we have some systems that have electric caps, and we see that 80% of the patients use their drugs regularly. Sorry, 50% of them receive their drugs regularly, and unfortunately, 17% of the patients, I mean 1/5 of them, only take 20% of the drugs they should be taking. This is why we have a high level of relapse. And this is for the patients who has a compliance rate over 80%. For those who have a compliance level of 70%, patients say that only 5% of them take their drugs regularly, and doctors are also asked, and doctors said that my patients take their drugs regularly. However, when we look at the reality, we see that 50% of the patients do not take their drugs regularly. So the patient doesn't need to tell lies, because sometimes there is a lack of insight about the disease, and also he is having problems with regards to taking drugs. I missed something. I need to go back. When you look at the NNT of relapse, NNT is 3. For antibiotics, it is 1. It's 100%. And antidepressant, it's 5 to 6%. And second generation antipsychotic, it is 6. But for relapse prevention, NNT is 3. This is terribly good, because we can prevent the relapse of our patients by using antipsychotic drugs. We have lots of drugs, and since 1970s there have been lots of drugs. For instance, flufenazine was the starting point, and then haloperidol deconate came later on to Turkey, but it was used in Europe. And in 1990s, zugdapentixol came, and then risperidone came, microcure version, and also olanzapine never came to Turkey, and paliperidone, 1 month and 3 month forms came, and also alipiprazole. So in practice, the disease onset is at the age of 20s for males and 30s for females, and they use lots of antipsychotic drugs. And after 4 different oral antipsychotics are given to these patients, they try all of them, and 11 years later, they are recommended long-acting antipsychotics. Even if the previous drugs were effective, they didn't want to have relapse. This is why they used long-acting antipsychotics as a last choice. I will be talking about their use, the use of LIAs. And when we look at who uses these drugs in Canada, if the patient is not sensitive, you can give long-acting antipsychotics to all patients. A group says this. And then there are some limited groups as well. But when we look at the schizophrenia patients, we can prescribe them long-acting antipsychotics. We can prescribe to 1/3 of them. It will be effective. So only 10% of schizophrenia patients receive long-acting antipsychotics, and the general indications tell us that it should be at least 30%. Why isn't it recommended? There are some reasons behind it. First of all, the knowledge of psychiatrists about them is limited, but it's not only about the knowledge, but their training and their mentality is also limited in this regard, and they do not have much experience, and this is why they do not recommend it, and they think that the patients will react to them. So when talking about long-acting antipsychotics, psychiatrists first start telling about their advantages without giving some information about these side effects and etc. So when this is the case, the patients feel more defensive. Who recommends, for whom are long-acting antipsychotics recommended? For non-compliant patients, for chronic patients, for antisocial or drug abuse history patients, and language problem. Especially if you have language problem with your patients, you can use long-acting antipsychotics. If the patient has history of aggression, or if the patient has symptoms of positive or disorganized symptoms, and also if the other drugs were tried and failed, or only succeeded for a little while, then you can give these drugs. And this is a hard-to-treat group, but you try to give the different drugs and try to get different results. But long-acting antipsychotics can be used for patients that are easy to treat, because you should use these drugs for patients who will respond to treatment, except for one thing, because you give it orally, then this could be a disadvantage for some group of patients, and therefore you can give injections for those patients, and they increase the blood concentration. But it's not possible to give them to the worst patients and to get the best result. But there is a paradox here. And there is a problem with regards to the use of the drug, because if the schizophrenia patients use their antipsychotic drugs regularly, it could be oral or it could be in form of injection, their mortality and morbidity risk reduce. Therefore, if they use it in injection form, the mortality risk is reduced by 33%. And I believe this is an advantage of compliance with the treatment. Is there any difference in terms of efficacy? When we look at the studies like PREDICT, we do not see much difference in terms of efficacy, because these patients are already volunteers and they take oral drugs, and there is not much difference between oral ones and the long-acting antipsychotics. But when we look at the naturalistic studies and the mirror image studies, we see some difference. What are they? Mirror image studies actually look at the exacerbation or admission of the patients, and then they give antipsychotics, long-acting antipsychotics to the patients. And what we clearly see is that mirror image studies show us long-acting antipsychotic drugs are much more effective. I hope I will be able to get my laser pointer as soon as possible. So, there is a new approach here. If patients with schizophrenia have some advantages, then why don't we use them for the first episode treatment? Because it has the same effect with the oral treatment, and it prevents the relapses in a better way, and it's very important to prevent the relapses after the first episode. So why shouldn't we use it after the first episode? It reduces the drug abuse or aggressive behaviors and admissions to the hospitals and damage to the brain, and it also prevents or reduces the psychosocial skill losses and IQ losses. And there is less debate within the family because the family members continue to say that you should take your drug all the time. And also this is an important cause of expressed emotion, and if the patient continues to use the drug and sometimes stops using it, this will cause more problems. So in pre-lapse study, it was found that if you ask the right questions to your patients, then, and if you use the right approach towards your patients, the patients will agree to use long-acting antipsychotics by 90% after their first episode. So this is the young group of patients. And while using long-acting antipsychotics, our main purpose is to prevent relapses. There is a reduction in the rate of suicide, and it reduces the compulsory admission to the hospital. So even if there is a relapse, the compliance is much better. And if there are any aggression symptoms of the patients, these symptoms are reduced. And if we give long-acting antipsychotics to a patient, then of course, we should not tell them that they will not take any oral drugs later on. Therefore, in the treatment, long-acting antipsychotics are a tool.
I mean, by saying that, I am targeting that there will be no oral medications, and building upon that strategy, sometimes we are required to provide oral medication as well. But what is the actual problem? It derives from pharmacokinetics. When we provide an oral medication, generally in 40-45 minutes through the guts, it is absorbed, and the concentration reaches the maximum in the blood. There is just one factor that could affect the most. It is the metabolization of this drug. Though in long-acting antipsychotics, this is the reverse situation. it is not elimination rate but absorption rate that decreases through the time. So we should just see the Cmax and how long will it stay in blood concentration and to provide treatment efficacy. And for that, while evaluating the treatment, we should see the pharmacokinetics features of oral formulations and long-acting antipsychotics. And then again, when we check long-acting ones, when we compare with the oral medications, it is independent from the first transmission impact. And we may provide this drug to less people actually. And also, in every intake, there is this time difference from the peak to the steady phase. Peak and deep differences could cause some impacts. In oral intake, it has more impact, and in long-acting once it is lower. Surely it is not the same case for every oral medication, but if there are more than two medications, for example, the situation is much severe in alendopon oral form, for example. We do not see that many side effects, but for risperidone, for example, the rate is quite high in oral antipsychotics. For 1 month and for 3 months, we can see the results. For example, risperidone's oral cure is also under 2. Peak deep difference is less, so if it is less, we see less side effects as well. And one of them is in this long-acting antipsychotics. And when we check it, what do we have in our hands? One of the oldest ones is flufenazine deconate, and I believe it is available in the market, so we still use it. It has advantages as a long-acting antipsychotic. Flufenazine's most important advantage is that after a very short period of intake, it could be observed in blood plasma. So it does not require any loading dosage. So we have the opportunity to decrease the dosage of oral medication as well. This provides us such a pharmacokinetics. We would like to have it in between 2 to 4 as a concentration, and it is quite fast, so we do not need to have any loading dosage from glutathione or deltoid. You may administer it. Half-life is 7 to 10 days. Tmax occurs in 24 hours. And also metabolic side effects are quite less. Flufenazine deconate does not require minimum loading dosage. We may provide it to the patients who would like to see the immediate action. For example, they will go to travel, but the aggression is continuous, so you may opt this one. As this does not require any loading dose, in the first dosage you may see the impact, and in every 2 or 3 weeks we can administer it. How do we identify if it is 2 weeks or 3 weeks, for example? If there is no need to have oral medication, 3 weeks duration is good. But if you would like to reach higher plasma dosage, then 2-week intervals will be better in order to see a new decisive situation in the blood plasma, so you will get better results. What are the disadvantages? it has a certain peaks from time to time in every dosage, and it could cause some dystonic reactions and tremors, and we do not see some of these side effects. So in other antipsychotics, you should be careful about the side effect profiles. In the past, aggressive antisocial or somehow patients who were not hospitalized because of some other reasons, it was possible to have this high level of concentration in blood plasma after at the end of 4 to 5 weeks. You may see the maximum dosage. Then you can just administer it in every 2 or 3 weeks. You don't have to wait for stabilization of your patient. Indeed, aggressive use of it is possible. If during the administration, if there are any APCQ, then you are above the required dosage. And the other one is zolpidem deconate. When we check the pharmacokinetics of it, especially as a deconate, it is available in the market. The Tmax is 2 to 3 days. 3 to 7 days, so you need to have 2 or 3 days to see the maximum levels. And upon administration of this, as in this form, you cannot just cut off other oral medication. You need to have some other concentrations, but the peak is different in 12 hours. So it requires 48 days to have its half-life. If you administer it at the same time, when one of them's peak is activated, the other is in decline, so there are no periods for the patient to have no medication. So it shows us another dynamic. If you provide zolpidem every single day, what will be the mechanism? There will be peaks in every single day. You will reach higher concentrations in a faster day in the following 3 to 4 days. When to administer it and how to have the absorption could be observed through this pharmacokinetics. Generally, they do apply in 2 weeks, but if you decrease it to 10 days, the blood concentration will be higher compared to 2 weeks. Haloperidol deconate, I believe this could be the most commonly used sort of form. And indeed, we do administer it in between 1 to 3 millimeters. We do not recommend higher dosage, so because the flows are not that good. Tmax is 3 to 9 days. So generally, in 3 to 5 days, we do see the first impact of it. At least for a while, you need to provide oral antipsychotics. It is quite bright in the background, so it is difficult to see it. As I've said, you need to use oral antipsychotics for a while. If you directly started to use haloperidol deconate, if they are just taking haloperidol in oral form, and if you are planning to transform from oral form to haloperidol deconate, you should just continue to use oral form for a couple of days to get the stabilization. We may just continue for 6 weeks if the patient is stabilized. During the pandemic, our team used another method very commonly. Haloperidol is quite suitable for loading. Actually, they do not take any oral medication. So every week we load haloperidol deconate. This is Tim Mayer's study. They've started with 100 milligram, but we experience 50 milligram as well, and the results are quite good. If you administer it in every week, the blood concentration increases, because the problem is that imagine that the patient is taking that orally. You had the injection as well. If you just cut off the oral, the concentration will decrease. So, if you have the injection and there are no oral or medication, there will be peaks in every single week, and you can just prolong the interval to 15 days after a while to get the desired concentration in plasma. Why we have practiced that during the pandemic? Because we couldn't hospitalize our patients. We started with a 50 milligram loading dosage, and if it is not reported in ATS, then if no problems have occurred in every 15 days, we have started to administer it, and we have stabilized our patients who are not taking any oral medication even. If any EPC or neuroleptic manic syndromes or catatonic risks are not existent, then you may provide this. When it comes to risperidol macro circus, this is one of my favorites actually. There are no major differences in between glutathione or deltoid. Tmax is 3 weeks. Half-life is 46 weeks, so there are ups and downs all the time, and there is no good stabilization. The constipation patients generally get oral medication. They have to continue using oral form for 3 to 4 weeks, because for microglobes it is required to have this time to have a desired level. Nearly all psychiatrists tried this, but I can't foresee the peaks. So in our clinic, it is not a common practice. And there is one another thing, maybe you have already experienced that too. Patient says, oh, you know, I had bad experiences. I had spasm, for example, after the injection, but you are surprised because there should be effects of the drug in 3 weeks, for example. But it is not the case. So in the first 24 hours, there is the release of this drug. So it is not surprising to see some side effects. It is eliminated very fastly. Just risperidone for stabilization. It causes certain problems. And another disadvantage, of course, it is not ineffective, but there are disadvantages. You need to keep it in the refrigerator, and if you just take it out, you need to consume it in 7 days, and you shouldn't put it in the refrigerator again. When it comes to polyperidone palmitate, it is different. This is risperidone metabolite, actually, and it has a burden on the kidneys, so for the liver it is not causing any burden. 60% of it just used in the kidneys. And polyperidone for patients who have liver problems may use it. However, for kidney problems, you need to be quite careful. There are lots of advantages of it. Surely one of them is that we may have loading dosage. Generally 150 milligram loading dose is administered generally in 8 days, plus and minus 4 days should be calculated as well. And there could be some report problems.
Dolayısıyla ne oluyor? Hızlıca bir yükleme dozunu ile
So immediately
yukarı çıkartıyor.
we increase the blood concentration to a higher level, and for stable patients we continue with lower dosages. As there is loading dosage, it seems that using oral medication for 1 week to 10 days is just ample time to have it, and
Şeye girdikten sonra, dolaşıma girdikten sonra
when it is in blood circulation, we do see the increase and decrease levels. The half-life is been between 25 to 49 days, and it provides us a 1 month using practicality.
bir dezavantaj. Dolayısıyla yükleme dozunu
Loading dose is recommended because if you do not have it, there is indecisiveness. The decisive plasma dosage could be obtained in only 2 to 3 months. So I suggest you to have loading dose. With the dosage, it could last for 10 weeks, plasma decisiveness. Without loading, it is 5 to 9 days. We provide 150 milligrams. And if the dosages concentration is low, then we may increase it. But for the bipolar preservation, we provide lower dosages like 50 milligram. But for schizophrenia, for example, we are not lowering the dosage under 100 milligram. And in general, when we check it, the average dosage, if there is a change of a drug, 100 milligram is suggested if you are cutting off the drugs of the patient. And if there are no receptor involvement, you may just do it immediately. Paliperidone, risperidone, aripiprazole, ziprasidone could be examples of it. But for olanzapine, quetiapine, and I'm not even including clozapine, you should just start the elimination process very slowly. When you cut these off, this could just flame the psychosis. And like acetone or piperidine could be administered for the patient if you would like to eliminate any risks. There are lots of advantages of knowing the pharmacokinetics. There are a couple of example cases. 150 milligram administered, then 100 milligram is for the continuation dosage. But they couldn't see the enough concentration. They then again continue with 150 kilograms. In the last week especially, you may see there are increases in positive signs. The dosage injection interval decrease from 28 to 21. Blood concentration is over 40, and when it is over 40, the symptoms decrease significantly. Of course, there are not that many centers to check therapeutic intervals, but if there are no EPS, and even though there are no EPS and you cannot just control the signs, there are no harms of having the other injection in 20 days. If you administered haloperidol, deconate, and if you see any side effects in the first 48 hours, then there is tendency for EPS. You should be quite careful with that. If you see any EPS in 2 days. And blood concentration increases with the dosage increase. Generally for 100 milligrams and 150 milligrams are quite good. We have such patients as well. In the prescriptions, there could be certain problems with high dosages. However, in a very short while, we do see higher concentration is available and the symptoms are controlled very nicely.
Kritik ilaçların
If you see the
hayatımızda
pharmacokinetics, then you may adjust the dosage quite comfortably.
aylık iğnedense
And
daha
other than monthly injections,
etkili ilaçlar
there are some effective. Isn't it better to have much longer acting ones? This has been developed with that purpose, actually.
aslında geliştirmedi.
Indeed, it is.
Kalbinden
They didn't develop it, but they just enlarged the palmitate molecules, and when they are enlarged,
erimeye başladı.
they started to just diminish very slowly. For the injection, you need to just shake it very nicely to have the homogeneous distribution of the particles. As the surface area is bigger, the half-life is longer. From deltoid, it is 84 to 95 days, and from the gluteal area, the half-life is 118 days to 139 days. Full clearance is available in 18th month nearly, and from deltoid it is advantageous. Why? Because in vascular structures intense, so Tmax could be reached very easily, and vascular structures help the drug to be absorbed much betterly. But with the weight increases of the patient, blood concentration could decrease. For obese patients, you need to be watching over that. With 1 month, you just stabilize it, and if you are using the same medication for 4 months, then you can continue to use polyperdone palmitate for 3 months. If you just skip, for example, one dosage, you may just turn to it. The most important disadvantage is that when the patients start to see the doctors in every 3 months, there is a decreased communication in between the doctor and the patient. So that is one disadvantage that I've observed. I will be talking about the studies, and there are no. It is not many different from the monthly version of it. The best phase 3 study available is this one. They do just follow up the patients for 3 weeks, and then they have oral polyperdol. And then they just continue with the monthly formula, and then continue with the quarterly formulas, 3 months formulas. After moving with the 3 months formula, we do see that there are 2 groups getting a 3-monthly formulation of polyperdone palmitate, and 1 group is placebo. Relapse rates are quite low. After first month, in the placebo group, you may see the relapses, and in a double-blind study, relapse rate is 7% for the treatment group and 23% for placebo group, as there is a huge gap in between treatment and control group. They are concluding the study in the day 274. As for clinical experiences, maybe there is a decrease in terms of efficacy through the last days of the 3rd month, but before increasing the dosage, so you should be checking that. Nearly 3 times fold of tretinoin is preferred. You may see it there are no differences in the first months because there have been 3 injections. But before Zeplion is reflected to this side in the double-blind phase, but through the time you may see the difference in between treatment and placebo group. In 2.5 months, you may just repeat the injection before increasing the dosage. I suggest you to shorten the intervals. There are certain post-hoc analysis as well. Nasopharyngitis is higher. This is interesting. Maybe not that significant, but you can see it when we compare it with the placebo group. Treatment group has a higher nasopharyngitis. In placebo group, one patient is dropped out because of a high fever, but we do not know the reason of it. And checking post-hoc analysis, both clinicians and patients are asked about the drugs, and patients and clinicians do prefer 3-monthly injections highly. And the ones who get 3-monthly injections get higher employability rates, and the burden of care decrease. And of course, in case of a dropout, relapses seem less. So Zeplion and Trevicta dosage. Trevicta dose is multiplied 3 times to understand the palperidone dose for Trevicta. If you have just cut off the medication in the first 3.5 months and 4 months, we do continue with Trevicta, but you should follow the guidelines, the protocols, because it could be quite confusing if the dropout period is 1 year or more than 1 year. It is challenging, and you should start. You should have a fresh start. As a consequence, for long-acting antipsychotic treatment, it is a very effective antipsychotic treatment, and it should be considered for patients who have suitable features. And as I've stated, they do need these loading dosages. However, you may think long-acting ones, clozapine, it shouldn't be a replacement for clozapine treatment. If there is a need for clozapine, then they need to get it. For EPS risky patients or some other patients who have risks for side effects, you should be quite careful with the use of it. It is suggested, but with careful watch with the EPS risks. And for neuroleptic syndrome side effects, we do see that it has been observed 0.1%, less than 0.1% actually. And for patients with pregnancy risk, the long-acting half-life should be a point of thought. You need to be careful with this long half-lives. And a 3-monthly schedule shouldn't be identifying your communication. The patient's visit to the doctor schedule actually. You should see the patients in accordance with the needs of patient, other than the dosage injection administration. You shouldn't load higher dosages for the replacement of clozapine, for example, or it will not be replacing your sessions with the patient. It is just a drug, and you should use it in accordance with that. Those are the things that I would like to say. Thank you. If you have any questions, I'll be pleased. Thank you, Ali, Saffet. As you have seen, we have a crowd of colleagues, so I believe it was quite beneficial. Thank you. 50 milligram Norodol Deponat. You have said it is not available. No, 50 milligram is available, but the studies have been performed with 100 dosage. We do not have 100 milligrams, so we couldn't. But by allocating with milliliters, you may have that. There are some studies trying up to 300 milligram, but generally those are criminalized patients. But if there are any colleagues working in the forensic services, for example, if the PS possibility is lower, then they may try it with 150 milligram in every 2 weeks. So I would like to start with a question, and we will have the discussion later on.
In general, there is a complaint about long-acting antipsychotics. People complain that after a month, the symptoms exacerbate and the drug dose is not sufficient, they say. So can we reduce this interval from 1 month to a shorter period of time? Yes, we see such problems and we reduce this time and we give the next dose on the 20th day, let's say, and then we talk our international colleagues. They say that they can reduce this time to 20 days. This is not a rule, of course. I mean, they're giving it every month. It's not a rule because there is a reduction, especially after the peak, or let me say the curve goes steeper. Goes down in a steep way. Therefore, we block the dopamine for a month, let's say, and the dopamine receptors become sensitive. Therefore, they need less blockage. They are given a less blockage, and this is why it causes exacerbation of the symptoms. Thank you very much. Now it's time for the participants to ask their questions or make their comments. Please introduce yourself. Hello, I would like to thank you very much for this interesting presentation. I'm from Balıkesir Social Mental Health Center, and paliperidone permetate is in my clinical practice, both 1 month and 3 month form. One of the pregnant patients I had a baby, and this baby is now 1 year old, and everything is going well. We are following them with child psychiatry and pediatricians, and the other one gave birth 2 days ago, and she asked me whether she could breastfeed her child, and I said okay, but I don't know what your experience is. The other patient is 23-year-old male patient, and he is bored of taking drugs every day. This is why paliperidone permetate, and this is why we use this drug. And the microparticles go into the blood. We know this for risperidone, but did you have the same effect with paliperidone? Did the patient take drug beforehand? Yes, it was olanzapine. Because of the weight increase, we changed it as well. There could be many causes of it. The easiest one can be that there may be still some olanzapine in the blood, and then you give the other drug because we know that there could be some dystonic reactions because the receptors are blocked more or there is a rapid reduction. Therefore, when you give it when there is still a high level of the drug in the drug, then this blockage will be added onto it. And I can tell you that one of the patients can be sensitive to this, and the previous antipsychotic dose could be, let's say, more than 60 or 80%. So you should have such a good transition that the oral effect would be going down, and then you should give the long-acting agent, because you're talking about a borderline patient, and maybe you can reduce the dose by 25% and then give the injection, and then you can have the climax, and on the 9th day there will be some more reduction by the dose. I mean, you can reduce the dose, but it's not always possible to predict it. Therefore, this is why I'm making this explanation, because if you discontinue olanzapine, it's an anticholinergic drug. Therefore, there is a possibility of dystonia or EPC. With regards to pregnancy, maybe you can publish those findings. It will be useful, I believe, for us and for all the other colleagues. I am just gathering all the data so that we can share them with other colleagues. Now, I believe it was about breastfeeding. So while breastfeeding, this drug will go to baby's body through the mother's milk. So although there is a reduced risk of EPS for the baby, my concern would be that about the receptors, because there's a dopaminergic process, and the child may be exposed to this, and this may lead to early onset of psychosis or some other problems, such as prediction error in cognitive functions, and it may cause some problems in the cognitive development. So I believe not breastfeeding this child would be a good option. There is another question or comment from the front row. By the way, Çağdaş will be making a presentation at 1:30, and I believe it will be much more exciting. I'm from Dicle University. My name is Mahmut. We give long-acting drugs, but with Zeplion. How many of your patients do you need an additional therapy? I don't see it frequently. We don't have to add some additional doses in the final days of the treatment. I don't see this in my clinical practice. How many of your patients need this additional dose? Of course, there could be some differences between the patient populations. I mean, you may be seeing naive patients or less severe patients. We are the tertiary healthcare center, and they are more resistant to therapy, and they require more aggressive therapies. But I can tell you that although it's not possible to give a specific figure or percentage, I remember the negative experiences more. It's around maybe 50%, I can tell, although it's not possible to give an exact figure. So the message here is that you don't have to wait until the end of the month to give the next dose. If there is exacerbation, then you can give the next exacerbation earlier, rather than increasing the dose, because if you increase the dose, there may still be a problem at the end of the month. So this is what I was trying to tell, because there may be differences between the patient groups. Maybe you may not have seen such patients, so you are lucky in that regard. Mustafa Yıldız, I guess, at the back row, will take the floor now. Thank you very much, Ali Saffet. This was a very good presentation. and we have learned lots of new things, and I can tell you that I want to underline something. During their stable period, we discontinued the drugs, and you said that you should give it around 20% of a dose. Maybe we should give it by reduced dose a couple of times a year, because this is a serious illness. Did I get it wrong, or is there anything wrong with this information? Can you please clarify that? And the other point is, for years, we have been giving oral therapies for our schizophrenic patients or psychotic patients, but we didn't succeed much. It was clear, and long-acting drugs are really important, especially for those who do not comply with the therapy. They are a very good option. We know this. And atypical drugs also appeared, and long-acting ones became more popular, and now it's used more frequently, and there is a higher chance of treatment or remission for our patients. But there is something we should not miss: pharmacoeconomy, because when we look at the prices of the oral drugs and long-acting drugs, we see that there is a huge difference, almost 10 times difference. So this is why we should be careful about while choosing them. And the pharmaceutical companies carry out some studies, and they support us, and then the admission rate is reduced, etc. But sometimes patients gain their insight in time, and they talk to their doctors, and 1 or 2 years later, they get better and better as a result of long-acting drugs. So should we still continue with the long-acting drugs, or should we shift to the oral form of the same molecule? My approach is that after 1 or 2 years of long-acting drugs, if the patient is doing well, then I would shift to the oral drugs, and I use this method, and they were really successful. And maybe this could be one of the areas of research in the future, and I believe it's very important in terms of pharmacoeconomy. Why? Because in 2005, I checked the prices, and in 2020, I checked them again. This molecule we're talking about, polyclonal palmitate oral version, let's say it's for 6 milligrams, and monthly price of it and the annual price of it is around 2,700 Turkish liras, if I was not wrong. For Zeppelin, it was around 14,000 Turkish liras. So when you compare them, it is 5 times higher. And I learned that the prices have dropped, although the currency is going up, the prices are going down. So it's good. It's good news for us. But there is still this difference of 5-folds. The new price is 1,356 Turkish liras for yearly medication, and for Zeppelin it is 7,800 Turkish liras. So it's around, again, 5 times higher. Therefore, some patients may need 3-monthly doses, but most of the patients should develop their insights, should improve their insights, and if they do so, we can shift to oral drugs. Maybe you have experience in this regard. What do you think about this? Regarding your first question, it was not about discontinuing the drug, but let's say that the patient is now stable, and the stabilization is ongoing for 6 months or 1 year, and
şikayet etmeye
then
başladı ki olabilir.
there could be some complaints.
O zaman her 2 ila 3 ayda
So every 2 or 3 months, we can reduce the dose by 10%. So
6 ay ya da 1 sene devam ettikten sonra önerdi.
after the stabilization is preserved for 6 months or 1 year, then I recommend this. Otherwise, it's not the case. So
Geliyor. Bir
it's almost the same amount.
EPS yok ise
If there is not a special EPS, or sometimes there is a sexual effect, so this is why we try to reduce the dose. Otherwise, I don't recommend it. So while preparing this presentation,
benim çabalarımdan biri şuydu. Belirli bir ilacı
I tried
bundan çok sizlere geniş
to
perspektif,
focus on
uzun etkili antibiyotik
providing a wide perspective for you in terms of the use of long-acting antipsychotic drugs. So
benim asistanlığımda da bize çok
the pharmacoeconomy is an important point, and it was also an important when I was a resident, but in years I have seen as a clinician and scientist that this is not my job.
konuda ekonomi yapıyoruz. Başka bir konuda
Okay, we can be economic about this, but on the other hand, we spend lots of money on other things. And we have a friend from mental health department, and now they are trying to check their productivity level, and it's hard to calculate this. So I stay away from it, and I am trying to provide a perspective for you, but we should always remember that every physician is responsible for the drugs they prescribe. I'm just trying to provide you the scientific information. We're quite late, so let's take a final question and then conclude so that we will have lunch. If you have any comment or question, we can take it now. Hello, thank you very much. This was really thought-provoking, and I really needed to learn about all this information. I'm from Antalya. Mükerrem Güven is my name. And for resistant cases, especially those who abuse drugs, is my focus group. I work with them, and I prefer long-acting drugs as a third option, especially for the psychotic patients or resistant patients, because in resistant groups you need combined therapies, and sometimes it's challenging because you can use other drugs, other antipsychotics, but which one to choose? So can you give us your recommendation about this? It will be good for me.
hedefinize bağlı olarak değişeceğini
Of course, it depends on your target, on your purpose, because let's say that for your patient, you want to have dopamine 2 receptor blockage, and you ensured this, but there is some problem with the sleep pattern of the patient. Therefore, maybe you should have, or you should choose a drug that will give some sedative effect. It should be one of those antipsychotics. So maybe olanzapine can be an option here, or quetiapine can be the option here. But quetiapine
farmakodinamiği itibariyle bugün
has a different pharmacodynamic structure. Therefore,
konusunda yarışabilmesi mümkün.
it's not possible to compete with other drugs to dopamine receptors.
Eğer istediğiniz
But this could be the target.
yakaladığınızı
Or if you think that you're not at the desired level of antipsychotics, but you don't want to give some more doses or additional doses because of any kind of a problem, then you can have amisulfate that will cause dopamine receptor 2 blockage. And
mesela
here,
yüksek
prolactin level may be high in the patient, so maybe at very low doses you can add ripiprazole. So it depends on your needs, on your patient's needs.
ve eğer hasta direnç
If the patient is resistant, then clozapine can be added to the treatment if there is no other contraindication. I don't know if this answers your question. Please do not hesitate too much, because most of those drugs are eliminated from the liver, by the liver. Therefore, you can combine them easily. For other drugs, I can tell you that your target is very important. You are using a long-acting drug, and sometimes if you need to pay attention to the oral absorption, you can use oral drugs, but be careful about this. I would like to make a comment too, because when we consider cost effectiveness, I can tell you that drug use and psychosis is very common, and I believe that long-acting drugs increase the quality of life for these patients and also reduce the legal problems as well. They have been using these drugs for quite a long, and I have learned that the prices have dropped, and this is a good news for them too, because sometimes it was difficult for them to purchase these drugs, and they were hesitating whether they could maintain their patients without the long-acting drugs. And the other comment is that we see that long-acting drugs are not much used in other countries, as far as I know. They don't use it so frequently. We are more comfortable in this respect. As clinicians or academicians, we're open to innovations, and we can use them. We can provide the necessary reports for them. Especially during the pandemic, the annual reports were used, and lots of drugs were given to the patients, and extrapyramidal effects were seen in all these three groups of long-acting drugs. And this was the case for paliperidone and other agents as well, because of the pandemic regulations. It was difficult to control them. This is why I give the reports for these drugs for shorter periods, such as 3 months. I agree with you about this, and I can tell you that I'm not much interested about this, because I see patients from Europe and from other countries, and it's all about your reimbursement system and insurance system and etc. But Residon and other drugs are available in other countries, but not in our country. I hope they will be available soon. Thank you very much. We will have another satellite session at 1:30 here in this hall. Thank you very much.